Hello, this is Dr. Jonathan Meyer, voluntary clinical professor of psychiatry at the University of California, San Diego, here to talk about the baseline monitoring and dosing of lithium. Well, here's a table that looks very intimidating, but guess what? Most of the stuff you're already doing anyhow. You have people on atypicals, you have a history, you have BMI, you have blood pressure, you probably have a chemistry panel. What's somewhat different is a couple of things here. We're going to get a TSH, not a big deal. When we get our chemistry panel, we want to make sure we have a GFR. The modern GFR formula removes the race coefficient. It uses two analytes, creatinine and cystatin C. The point of getting it is you want to know what it is before you start them on lithium. There's a lot of people out there who we see with severe mental disorders who have high rates of chronic kidney disease risk factors. Hopefully you'll note that in your history, but some of these people are completely untreated. They're not even aware that they're hypertensive. And then lo and behold, they have subnormal renal function where you're the one that might diagnose it. Pregnancy tests for people of reproductive age who are women doesn't mean that you can't use lithium in this population. In fact, we now know that the risks for certain outcomes with first trimester exposure, like cardiovascular anomalies, are much lower than we previously estimated, but they're not absent. And so you want to know before you start somebody on lithium what the status is. Importantly, we now realize we can't give out Pro-A to women of reproductive potential, so you need to know how to use lithium in this population. The urine albumin to creatinine ratio is a marker of glomerular pathology. If you have trouble with glomerular pathology, you leak albumin into your urine. Well, lithium doesn't really cause that. This is caused by comorbidities such as hypertension, prediabetes, metabolic syndrome, diabetes. The reason we might get this is in people who have some of these comorbidities or already have lower than normal GFR. The staging of this is helpful. The reason you want to get this is a lot of these people will have comorbidities. Maybe no one has obtained an albumin to creatinine ratio or an ACR, and this is typically obtained on an early morning urine specimen. And they'll blame everything on the lithium. And this is your defense. Well, hey, guess what? Their poorly managed hypertension was a problem, and they already had stage A2 albuminuria as measured by the ACR. An ECG or an EKG is not absolutely necessary. In some places, you have no choice, and that's fine. Why would you get it? Well, if you have people above the age of 40, especially those with cardiac risk factors, you're really looking for other untreated conditions. There was a warning in the package insert about Brugada syndrome. This is one of those channelopathies. The number of cases of people having problems related to lithium is extremely small. We're talking 12 or 13. But by getting an EKG, you can pick this up. And when would you suspect Brugada syndrome? Well, people say, I don't know, I've had a funny heart rhythm. They can't tell you any more about that. There's other cardiac diseases already present. Most importantly, if they've not been diagnosed, these are the types of people who might say, I've had recurrent episodes of syncope or near syncopal episodes, or they've had people who had sudden death before the age of 45, or rarely they'll actually say, oh yeah, someone in my family has Brugada syndrome. That's why you get this. It is diagnosable just on the basis of the EKG. All the machines are programmed to look at the characteristic pattern for this. You will probably never find this. I've seen this once in my clinical lifetime. But if you diagnose somebody, you've really done them a favor, and then they can go get appropriately worked up. A lot of people who are picked up on the EKG really are not at risk for sudden cardiac death, but they need to be worked up to make that determination. And it's important that you get them assessed. Can you use lithium in some of these people? Absolutely, you can. It's not a contraindication, but it's going to require some workup. So ask these history questions. It's unusual, but you do want to know. History of syncope, near syncopal episodes, people dropping dead from cardiac disease at young age, somebody who has Brugada syndrome, ask it, and then get the EKG. Here's some other optional items. The EMUO is to look at people who are having trouble concentrating in your urine. Well, that's not normal in the population. Sometimes among older individuals, you start to see some of these problems creep in. You could get it there. It's not absolutely necessary. Why do I say CBC? Well, lithium raises your neutrophil counts. It's good to know what the person's baseline is because the neutrophil count's going to go up. That's the only reason. At least you know what it normally was, and if it goes up. The important thing is actually you want to educate patients about this because every once in a while the other provider is not aware the patient's on lithium, the neutrophil count is up because they needed to get a CBC for some reason. They suspect some occult infection or some hematologic abnormality. A1C and lipids have nothing to do with lithium, have everything to do with the people who are getting lithium who have higher rates of these problems. And especially if you have people who have more severe forms of mental illness like schizoaffective disorder, bipolar type, they may not have a primary care provider. So you're doing them, again, a good deed by screening them for diabetes and dyslipidemia so it can be appropriately managed. Plus, if these things are poorly managed, it's going to cause a problem for being on lithium because these are the things which are going to cause the chronic kidney disease, even beyond whatever use of lithium may or may not be considered in that population. Non-renal lithium monitoring is relatively straightforward. You get vital signs every 6 months. We do this in everybody anyhow, especially most of these people are going to be in atypical antipsychotics. You only get a follow-up EKG if they needed one at baseline. There's some places where you have no choice, but if they needed one, you'll get one at follow-up just to see what the lithium-related change is. Most of these changes are completely benign, but if it's needed at baseline, then you want to get one at least in follow-up. Serum calcium and TSH. Why? Well, most of you know lithium can cause hypothyroidism. It's not a reason to ever stop lithium, but you want to detect it so you can treat it. Lithium can also cause hyperparathyroidism. It alters the set point for calcium monitoring at the parathyroid level, and sometimes can actually cause microadenomas. You want to detect it early so the people can be treated. When you start somebody on lithium, you're going to follow, of course, various aspects of renal function. I'm just reiterating that. This has been included in other teachings that we've done in these modules, but I just wanted to throw this in, even though it's clearly renal, just so you understand how often you need to do this. And a lot of these things will be batched. You'll get your calcium, your TSH at the same time as your level and your GFR. To reinforce again the levels that we're shooting for. For acute mania, we never want to exceed 1.2. And the reason being is that's associated with more renal dysfunction. If the person's mania is not controllable and their level is getting close to 1.2, and often these people are already on antipsychotic, you're probably going to need a second mood stabilizer. You simply just don't push levels to 1.5 the way we did in the old days. For maintenance, the sweet spot is now considered zero point 0.6 to zero point 0.8. You can go up to 1 if the person needs it, but never above 1 chronically. And there are some people who actually can be managed between zero point 0.4 and zero point 0.6. Their brain will tell you what it needs. But if the person cannot remain stable with a level close to 1, again, this is somebody who will need adjunctive medications to help manage usually the hypomania, which is not controlled by lithium and maybe lithium combined with an antipsychotic. Much less literature on bipolar 2. We tend to use levels kind of comparable to bipolar 1, but because there really is no risk of mania in bipolar 2, it's only hypomania, we'll often start with levels of 0.4 to zero point 0.6. And for adjunctive use, we use lower levels for unipolar mania. I've talked in prior episodes about using lithium once a day. That is now the standard of care because multiple daily dosing causes more renal dysfunction. The other thing is multiple daily dosing distorts the level. If I'm on, for example, 450 milligrams twice a day and I get my level tomorrow morning, well, it's a 12-hour level only for my evening dose, but the other half of the dose was taken 24 hours before. So what happens is if you take somebody on BID dosing, you put it all to QHS, and then you recheck that 12-hour level, guess what? That number will go up by 28%. They're still on the same amount of drug, right? Same amount of drug, but now you get that true 12-hour level because it's not being distorted by BID and distributing the level over 24 hours for half of it before the level was obtained. So it's important to know this. We prefer to always give lithium once a day. You may have some patients who refuse to switch. And if they refuse to switch, you should take that level which you're getting on BID dosing and multiply times 1.28, because that's the level they would have if you put all of the drug to QHS. And you might recognize that you're actually giving them nephrotoxic levels of lithium because all of your decisions were previously based upon the level obtained on BID dosing, but we know that level is being distorted by the fact that the drug is spread out over 24 hours. This is showing you the levels over time and the kinetics of lithium. Doesn't matter what form you give people, carbonate, capsules, tablets, citrate, you can even get orotate on the web. The only reason we typically use sustained release preparations is simply because it lowers the maximal levels and delays that peak a little bit by a few hours, and that can lessen the nausea. But the half-life in your brain of lithium is 28 to 48 hours. There was never an efficacy reason based for giving lithium more than once per day. It's just an artifact of history. And you can start people on standard lithium. If they have nausea, you can go to a sustained release preparation. To be honest, if they have diarrhea, it means the ion's being delivered too far south. If they're on sustained release, go back to regular lithium. If they're on regular lithium, they still have diarrhea. You can have them take it with dinner. But we always get levels roughly 12 hours after the dose. Doesn't matter if they're on a sustained release preparation or standard lithium. I give you some equivalences here, and it's important to know that. In lithium carbonate, in case you had any doubt, the active ingredient is lithium. And 300 milligrams of lithium carbonate contains 8 milliequivalents of lithium. And when we order lithium citrate in some packages, some EHRs, you'll actually order it based upon milliequivalents. 8 milliequivalents equals 56 milligrams of elemental lithium. And the reason we know that is you take milliequivalent, you multiply times the atomic number, which is 7. But importantly, 300 milligrams of lithium carbonate contains 56 milligrams of elemental lithium. You should know that because you can buy elemental lithium on the internet in the form of lithium orotate. Sometimes people take a lot of this and they can make themselves lithium toxic. So this is a way of quantifying the exposure if they're buying it themselves on the internet. But again, once daily dosing in the evening, all your decisions are based on 12-hour levels, regardless if it's a sustained release preparation or standard lithium. As the level gets more and more away from 12 hours, it starts to distort because it's not perfectly linear as you get for longer periods of time. So as much as possible, try to get people to take their drug at night and get the level 12 hours later. Don't dose lithium at noon because you'll never get a 12-hour level, and certainly in the morning you'll never get a 12-hour level. You'll get levels at these odd times and they'll be completely uninterpretable. Another reason, again, to mash it all to evening dosing. And this table down below shows you the impact of multiple daily dosing and how it distorts the level. In all of these studies, they took people on BID dosing. One, in fact, was TID, and then they mashed it all. It says QD, but it was all evening dosing. And then they recheck the level, and you see, in general, on the same dose, the same amount of lithium, that level now goes up 28%. We didn't increase the amount of lithium you were taking. All we did was get a more accurate 12-hour level. And that's why people were fooled. They think, oh, this person's level was 0.81 in the third study by Greil. That's fine. Well, really, that level is above 1, and chronically, that's going to cause a lot of renal harm. And it's an important lesson about the dangers of multiple daily dosing is that you're really not getting the accurate level. Once you push it all to QHS, your level will go up on average 28%, and you might realize, gosh, I was exposing somebody to more lithium than they really needed. So how do I start lithium? Well, it depends on where you are and the state of acuity. Going up slowly obviously minimizes tolerability issues. You're rarely going to overshoot because you're going to go so slowly, you'll be able to get levels. The disadvantage is, of course, it takes time to get to a therapeutic level. And the best place to do this is, of course, in outpatients with modest symptoms where getting to a therapeutic level is not crucial right away. And maybe if you're worried about rapport or the patient balking if they get adverse effects, these will happen slowly and you'll have time to manage them. When do you get a level? Well, it's 5 days to steady state. The half-life of lithium is 24 hours. So every time you change a dose, you want to get a level about 5 days, or a week later, but not longer than that. You want to know the answer as soon as possible. Sometimes people say, well, when in the titration should I get it? It depends on a number of factors. How often can they go to the lab? What's their baseline renal function? If somebody has excellent renal function, they have a GFR of 115, you're probably never going to overshoot. And so you may want to minimize the number of times they have to go to the lab and get stuck. On the other hand, if you're shooting for a higher level, somebody whose renal function isn't outstanding, but it's acceptable to start lithium, you may be checking them a bit more often. The most important thing is that every time you change the dose, you get to a dose which seems reasonable, get the level about a week later, and then make your decisions based upon that. There is a test dose method, though, which is very interesting. And the idea is, and this is done kind of reliably in large groups of people, is that from the 24-hour level after a single 600 milligram dose, it can predict what your maintenance dose will be to keep your level, which back then was in the therapeutic range of 0.6 to 1.2, with an extremely high correlation coefficient. The nice thing is it avoids using some of these really arcane predictive formulas which try to capture every patient variable possible, because this 24-hour level is a product of all of those factors. Their age, their GFR, comorbid medications, everything. And the disadvantage is you really do have to get the level at 24 hours after they take that test dose. If you have a reliable person, it's wonderful. Inpatients, absolutely, you can do this. Outpatients, maybe not always. So in the table, I give you what the 24-hour level will be and how you act on it. So Tom Cooper was the first author of this paper. You can see this paper was written in the 70s. The second author is George Simpson, who is still alive in his late 90s. They based everything on the old, TID, BID dosing, which we do not do anymore. I converted those all to QHS dosing using the appropriate math with some footnotes there that, if you really got a level that was undetectable, probably you're going to have trouble giving this person enough lithium to get it therapeutic because they're going to need fairly whopping doses. So it may become an issue. Hopefully you won't run into that too often. And of course, if your level at 24 hours is too high, meaning it's above zero point 0.3 for that single dose, they're not going to be a candidate of lithium anyhow. So this is useful. You can use it on inpatients in particular because it'll give you the level that will help you get a dose which is going to be reasonably therapeutic for that population. You can also use it for outpatients too if you want to avoid having to do a lot of titration. There is another method, which is a loading dose method. So in some parts of the world, this is actually used. People are familiar with the formula 30 milligrams per kilogram because that was the loading formula for divalproex. Why is this useful? Because when you load people, you get them to steady state faster. So the optimal situation is always going to be a manic inpatient. So the study that did this used a 30 milligram per kilogram formula, but they didn't give it all at once. What they did was they broke it up into 3 doses, and they roughly, equivalent, 10 milligrams per kilogram each. Bearing in mind lithium comes in odd doses. So if you had somebody who was 2,100 milligrams as their predicted dose because they were 70 kilos, well, maybe you would do like 600, 600, and 900. That ends up to 2,100. But you split it up every couple of hours, and for the loading procedure, they use a sustained release preparation just to minimize the nausea because they're giving people a lot of lithium over a period of 4 hours. But when they did it using this formula, it was all well tolerated. No nausea, diarrhea, or other GI distress. People did quite well, and the levels they got were reasonably at 12-hour levels within a therapeutic range. There were some women who were obese where the formula tended to overpredict the amount that you give people. So if you have people who are obese, in particular women, maybe you only do 20 per kilo. But the point being is that it gets you to a therapeutic level sooner. If you have somebody who's manic, lithium does something which is very distinct than what the antipsychotics do. I know antipsychotics are indicated for mania, but the point being lithium does something very distinct. We do not want to send manic people out on antipsychotic monotherapy in this day and age. They tend to have higher rates of treatment failure. So here's a way that you consider starting lithium by loading it, but make sure again that the loading doses of lithium are a sustained release preparation. The following night, based upon the level you get that next morning, you'll use whatever form of lithium you want. But initially, it should be a sustained release preparation. Again, lithium has a half-life in your brain of more than 24 hours. You can use whatever form you want chronically. The value of a sustained release is really minimizing upper GI side effects, predominantly nausea, and that's why it's used for the loading procedure. Thank you very much. This is Dr. Jonathan Meyer. If you